All right, syncope and hypertension. What are we going to do first here? Take a little blood pressure. There's the Joint National Committee on Definitions. Why is definition important? Because you make disease by the definition. It depends on what number we pick. For example, they've got something here called prehypertension. What is that? We don't know exactly what that is, but we've now decided it's a disease. You see, the problem is, as soon as you start deciding what's a disease, then you start limiting people from other things, maybe from jobs, the space program, the this or the that. Be very careful about giving out disease classifications. I can relate to stage 1, the systolic 140, 159, diastolic is listed. But understand that we have these classification systems to decide on therapy. Hypertension in the ED, let me summarize this very quickly. There are very few people who need to have their blood pressure lowered acutely. We did all kinds of stupid crap when I was young in medicine. We were treating people with 160 over 100 and stuff like that. We had no idea what we were doing. And we did more harm than good in a lot of cases. So, number one, most people don't need treatment. By the way, most people, they'll come in and say, I can tell my blood pressure's up. I've got a headache. Well, you know what? There's no data that supports that. Their blood pressure may be up, but it may be always up. They may be just fine, you know, no headache at all, and still have increased blood pressure. Remember, blood pressure is the silent disease. It's the one that doesn't do anything. Don't treat a number. Treat the patient. And don't pretend that emergency department care and intervention is the same as long-term following a patient. Now, everybody in my career in the emergency department has always said the same damn thing. Their blood pressure's up because they're nervous. It's white coat hypertension. How many people have heard that? Yeah, they'll be fine when they go home. Well, there was a very big study done in New York. Hey, you know, New York. Well, your blood pressure's up. So they brought everybody back when they weren't under stress and just took their blood pressure. 50% of them actually had some form of hypertension. So you never write it off as the visit. What you say is, here's your blood pressure today, have it rechecked. Here's the places to go, here are the people to do, all that kind of stuff. Have it rechecked and document it on the chart. Do I have lawsuits against emergency departments that didn't do that? Yes, I do. And the bottom line was, they had the opportunity to intervene. Just understand, you never ask a question you don't want to know the answer to. Whenever you do a test like blood pressure, you've asked a question, right? For example, I never ask my wife if she's cheating on me. Children seem happy, she seems happy. What's the answer I'm going to get that's going to make me happy too? But if you ask a question and you get an answer you don't like, you've got to do something with it. That's why I'm a conservative on testing. Don't ask, don't tell, don't know. That's okay with me. But once you have that number, you got to do something with a number. Now, the best thing you can do is take their blood pressure on the way out. If you have an abnormal blood pressure on the way in, I don't understand why you wouldn't check their blood pressure on the way out. Then you can reassure them. That would be a good thing. But what you can't do is leave a dangling number in the chart. It's unacceptable, and by the way, it'll come back to bite you in the butt. Now, hypertensive urgency. This is diastolic pressure above 110. Almost no signs or symptoms. Acute intervention may be harmful. What do you want to do? Somebody who's now 62, they've had that blood pressure for a certain number of years. What do you do? Drop it? Acutely bring it down? That's craziness. Now, there are some people who say, well, call their doc, start them on a little bit of, a light, mild medication, have their blood pressure rechecked on the outside. Okay, I guess I can relate to that, but it's almost never a site of immediacy. You don't have to do something to plunge their pressure. Nobody has got a study that said normalization of the blood pressure in mild hypertensive urgency does anything to change the outcome. Blood pressure, I think, is a disease and a problem, but it's one treated over time. Sudden treatment of blood pressure, almost never any good. Hypertensive emergencies, this is when there's end organ damage. What does that mean? This is big time stuff. There's no specific number here, but what we know is if you've got a blood pressure, 220 over 200, and you're infarcting at the same time, this doesn't sound good to me, okay? It just doesn't sound right. Let's say your brain is funky. You've got encephalopathy, eyes, kidneys, that sort of thing. The most common one we run into probably when we talk about encephalopathy and these sorts of things are pregnancies. When you see somebody with that blood pressure rising who's about to deliver and now they're becoming encephalopathic, you've got a problem on your hands. You've got a problem. This is an indication to lower the blood pressure somewhat, bring it down 20% or so. This is a true hypertensive emergency. Are there pediatric hypertensive emergencies? Sure there are, but the number of them is relatively rare. There are strange tumors in kids. I have in my career had a child who had a pheochromocytoma. And it was this, you know how God sometimes sends you things? Said, my kid doesn't look right. And I said, well, that's very interesting. See, the mother actually looked at me and said, she looks a lot like my other kid. Here's the letter from the university that they had. What did they have? A pheochromocytoma. Oh my God, thank you. We were able to figure it out. Know that you're treating something called the mean arterial pressure. Know how to figure the mean arterial pressure. You don't have to have integral calculus to do this. We have a simple formula there for you. But when you really need to drop blood pressure, to me, I use the opposite order here, it's labetalol and last nitroprusside. You understand that nitroprusside is broken down into cyanide. It has its own side effects. It has its own problems. So think about it. Ischemic stroke, we've talked about this. Dropping blood pressure in those people is incredibly controversial. Ischemic stroke, we don't know how far to bring it down. So if they had 240 over 200, something like that, you could argue they bring it down 20% or 30%, but nobody suggests that you normalize the blood pressure. Nobody thinks you should drop it to 140 over 80 because invariably they need certain heads of pressure to perfuse their head. All right, let's get to the pregnancy-induced, the hypertensives, the eclampsia. The only difference between pre-eclampsia and eclampsia is what? The seizure. Now, let's pretend we'd like to not have seizures. I can agree with that. You can go ahead, you can start them on the magnesium yourself early on as a prophylactic measure against this. Hydralazine and labetalol. Again, labetalol comes up when you need to drop pressure. You're going to do it through, and remember, anything that has LOL on the end of it is a beta blocker. Doesn't matter which one it is. If it's a LOL, the blood pressure is going to go down. We don't know how much, but that's where I would go. Labetalol, hydralazine, and magnesium, maybe in advance of the seizures. What about cardiac emergencies? Again, IV nitroglycerin may be the drug of choice. Why? Because we know which sides of the limbs it works on. I'd go IV nitroglycerin first, nitroprusside second. The beauty of nitroprusside is we can control it minute to minute. Turn it on, shut it off, but it has its own side effects. Be careful. Aortic dissection. All of you know that type A's, the treatment is surgical. Type B is debatable. And the first thing you do with those on that side of the loop is drop the pressure, because you want to block the shearing forces of that contraction against the wall of the vessel. So again, drug of choice there, beta blockers, perfectly good, propranolol. You want to get those going first, and then nitroprusside if necessary. Move on for just a second here. Let me spend a little time with labetalol, my favorite. It's alpha and beta effects. Remember that, because it's primarily beta, but you will get both sides of the limb, no question about it. It has an onset of action 5 to 10 minutes, but it will hang around for 6 hours. So you can't just shut it off and it disappears, but very good in people whose blood pressure is rising, warning. This is not the ideal drug if they have bronchospasm or AV blocks. When we say treat the patient, I can't be firm enough about this issue. I've seen all kinds of people started on a medicine, not followed up, and there are side effects. Who are the people who get the worst of this? Number one, the elderly. Because somebody has taken one blood pressure, now it's up. Do you realize they are hypersensitive to medication? So now, Grandma stands up, and what happens? We're picking her up off the floor. Now we could treat her broken hip. It's very good. The orthopods love this. You know, this is what happens when you start to play doctor on long-term disease from the emergency department. And so I am not a fan of regular outpatient medication. All right, move on to topic number 2, syncope. What is syncope? It is sort of an immediate loss of consciousness. They go down, and then there's a return of consciousness. See the guy here with his face in the plate. This is not somebody who goes down and stays down. It is completely out. You know what we call that? Coma. That's coma. That's a different set of diseases. So syncope is quick up, quick down, wake up again. That's syncope. Some causes are benign, easily diagnosed. Some of them are deadly and some of them aren't. But have a view of this when you're working these patients up. Every study you get, there are yeses and nos. If you're given an EKG, you should have a list of things you're looking for, yes or no. What's the rhythm? Is there a block? Is there Brugada's syndrome? You know, what is the intervals? All of those things are specific yeses and nos, which you ought to look at. By the way, in taking the history, listen to people who saw the event, because sometimes it may be their first seizure. We don't know that, but somebody may have noticed something we need to know. Did the patient get a sense of graying out, or were they just gone instantly? The next thing you knew, they were waking up. Most seizure patients don't remember the event very well. People who gray out, particularly from cardiac reasons, often have a sense of going down. That's worthwhile to know. The elderly are particular risk. If you look at all the data, let's just clear all the crap away. If you're under 50 and you have a normal EKG, the chances you got something real bad are real small. Now, I've had some interesting people in my career. I've had people with micturition syncope. For reasons of having a hyperactive autonomic nervous system, guys come up to the head there, they start to pee, and down they go. But the story is reproducible. We can figure it out. I had a guy who had swallow syncope. He was brought in by his friends because he'd have a big drink of a cold beer, bend over to make a pool shot, would go forward and rip the felt on the table. And I had him brought in by two friends who wanted to beat him up for ruining the pool table. But it was a very interesting, we can figure some of these things out, and but in the elderly, as soon as you get past that 50, God, I hate to say that. Jesus, I hate to say that. When you get over 50, it's usually not a good thing. Variety of things to do. Here are the syncope causes, quote out, the pass-out causes, pressure problems, vasovagal. With old people, you always look at the drug list. We have all kinds of things that give orthostatic hypotension. We have all kinds of them. All you got to do is look at the drugs they're sticking in their eye for their glaucoma may be the problem. I've seen that several times. The other thing in the elderly, there is the 1-second workup. You look at the rhythm strip and you check their butt, smear it out, is there any blood? I can't tell you the number of old people there are in this country who are slowly bleeding down. They don't feel so bad, and finally, they come in with a 6 hemoglobin. They were standing there at the bus stop longer than they should have. Boom, down they went. This is the kind of nickel-dime stuff which is so easy, so cheap, so fast, but don't miss it. Costs you no money, and you do pick up things this way. It's very good. Arrhythmias, as I pointed out, when you pick up the EKG, have a plan. There are about 5 things I look for on that EKG. That's it. I mean, there's going to be some subtle stuff I probably won't see, but the things that cause syncope, you will. It's a yes and no question. The intervals are yes and no. Brugada syndrome, yes and no. Those things are pretty simple. Seizures, we talked about. And again, depending on the age and the neurological exam of the patient, you may want to look for that. Obviously, if they have bite wounds inside the mouth or the tongue, they have incontinence, those sorts of things, that would make you go forward. Sugar is listed on here. I don't believe that. I saw that in my first book at about 19. I was writing a book on neurodisease, and I called up Marty Samuels at Boston. I said, you've got this in your book, Marty, on syncope. Would you give me the reference? He says, there isn't one. But he says, everybody else, he said, Raymond Adams put it in his book. I said, I don't know what that means. Most people with sugar don't actually go down, bang, in a second, and are bang back up. They're usually still out for a while. We throw it on the list, but understand, that's not the usual story in sugar. Cardiac output questions it can be a part of it. Let me get the other thing here, get to this. The important things are the history has to discuss what happened, who saw it, what were they doing, what's in the drug list, what's in the other problems they've got going on. The CT does not routinely have to be done on these patients. When you think about it, why did they go down? It's going to have to be they either seized, which you're not going to see on the EKG. Now, or even on a CT, you're not going to see that sort of thing. Now, okay, let's say they're a person who has metastatic breast cancer. Would I go ahead and do it on that patient? Yeah, sure, but it's patient dependent. And understand that most syncopal cases aren't solved by looking at the CT scan. It's just not right. A lot of these have to be very individually decided. Here is the algorithm, which is in your book. You can go down these various pathways, but understand this. None of this is perfect. There is a gestalt to the patient in front of you who are going to need things. Most syncopal patients, without an obvious cause, are going to have to be monitored. You are going to have to figure out whether they're going to need to have a pacemaker, those sorts of things. But it is not just this simple algorithm that makes the decision. So let's think about the disposition of these patients. Some of them can go home. Some of them can be worked up as an outpatient. However, consider admission for grandma who's 90 never done this before. On a statistical basis alone, she's going to be dead in a couple days, isn't she? You don't want to be the last doctor to have touched somebody who's going to be dead in 2 days. I promise you that. And on a statistical basis, she's dead already, so just be careful. If you have congestive heart failure and you went down, this is a bad sign. They come in. CHF, syncopal attack, admitted. Patients with a pacemaker, you got to find out whether that's abnormal or not. Patients with an abnormal EKG, we got to take care of that. And if that exam picks up anything else, odd murmurs, again, blood coming from the rectum, those people really need to be admitted. There you go, ladies and gentlemen. Thank you very much.